And to introduce our first speaker today, I think we're very, very fortunate to have probably the man that's has probably more influence on dentistry in our state than any other person. He does it well behind the scenes, but he is influential in the Dental Society, in the New York State Department of Health, and in addition, outside of the state, and he has influence also. Dr. Jayanth V. Kumar received his DDS from Bangalore University in India. He had a master's in public health from Johns Hopkins. I know, Dave, you're very happy about that. And a residency in dental public health at the New York State Health Department. His topic today is the role of government in public health and improving oral health. Dr. Kumar, as I mentioned, is at the Health Department. He is actually the Director of Oral Health and Surveillance and Research at the Bureau of Dental Health. He is Associate Professor of the School of Public Health at the University of Albany, a Director of the New York State Public Health Residency Program, actually has one of his residents with him today. Where is she? There she is in the back row. In addition to that, he's a diplomat and past president of the American Board of Public Health. He does participate in a limited private practice, so if you think that he is only in the ivory tower and doesn't understand your problems, that's just not true. Dr. Kumar, as I mentioned, is recognized nationally. He's an expert in relation to water fluoridation, dental sealants, and oral public health for both the CDC, ADA, or the Academy of Science, and other national organizations. He has published well over 50 articles on these subjects and recently developed an outline for the oral care of pregnancy in early childhood. This is sought after in the other 49 states and is kind of the first time that this has been done. Please welcome with our distinguished speaker, Dr. J. Kumar. Get the pad back.
Okay. No, I don't need it. Yeah. Good morning. Can you hear me? Okay. Thank you, Tom. Thank you for that kind introduction. This is my third visit in the past 3 years, I think. It's all because of Tom Curran. I've come here to talk about oral health care during pregnancy. I've come here to talk about water fluoridation. And I think this is the first time I'm here talking to the Dental Society members about the role of public health. So that's my topic. Oral health has attracted a lot of attention, and Corning has attracted a lot of attention recently. And it's all because, I think, of the fluoridation and the battle that you have waged here in this part of the state. What I'll do is, today I'm going to talk about how public health decisions are made and what are some of the underlying basis for making those decisions at the state level and at the national level. And I'll talk about oral health problems, the magnitude of oral health problems nationally and also here in New York State, not only among children, but I'm also going to talk a little bit about other population groups. And we'll discuss a little bit about available interventions. And then I want to talk about the recommended strategies in the state oral health plan. Tom had asked me to bring our state oral health plan, but it was too heavy to bring it, so I didn't bring it. I'm mailing it, and every dental office here will have a copy, Tom has assured me. So you will get to see some of the strategies and the basis why we have recommended some of those strategies. And we will be updating that in about 2 years. So if you have any thoughts about that, if you want to participate in the process, please let me know or let Tom know about it. Tom, it's wonderful to have champions like Tom Curran. It's a teamwork, and we need champions in every community. I'm so happy that Tom has taken the leadership not only here, but also at the state level. He's on the MCH Block Grant Council, and the first dentist member on the MCH Block Grant Advisory Council. So he has tremendous influence on how the money is spent on maternal and child health programs in New York State. So in the next an hour or so, I'll talk about some of the public health approaches that we have taken, recommended in New York State and nationally. So we start with a problem, and we have to define the problem. And for every problem, we try to find a response. And when people ask me, what do you do at the state health department? What exactly you do? Do you practice there? Do you treat patients? Generally, generally what I do is I like to compare public health practice with what happens in private office. So the IOM, that's the Institute of Medicine, put together a report called The Future of Public Health. In that, they identified the role of state public health agencies. So I usually give that response. That is assessment, policy development, and assurance functions. So how do these functions compare in some of the activities that take place in a private office? So this is probably the easiest way to communicate these functions that we undertake at the state level. Assessment is something very similar to what you do in private office, that is diagnosis. Only difference is we do it at the community level. So we like to see we like to diagnose what are some of the problems at the community level. And once that is done, generally what you do is we come up with a treatment plan in practice. So at the state level, we like to come up with a program plan to address some of the underlying problems that we identify at the community level. So the next thing, once the treatment plan is outlined, the next thing is to carry out the treatment. Similarly, we like to undertake programs. And there are a lot of details when we develop the program, very similar to what happens in a private office. We have to identify what are some of the specific goals and objectives of this program. We have to undertake, we have to mobilize the community. We have to, sometimes we have to pass laws to undertake some of these activities, change the regulations, and most importantly, we have to find money, something very similar to what happens in private office. So we have to find a way to finance dental care, and then we have to train people to do some of these activities and develop a monitoring plan, and that is evaluation. So it's almost very similar to what happens in private practice, bringing back patients to see how well the treatment has worked. So we have to go back and evaluate the program to see how well the program is working and what changes are needed in the program. So we don't recommend solution to every problem. So we use certain criteria to define what is a public health problem. It has to be widespread. So the definition of what is widespread varies from condition to condition or illness to illness. For example, you may have read about the epidemic of AIDS or HIV infection in Washington, D.C. About 3% of adult population in D.C., they are infected with HIV. So that is a major public health problem in Washington, D.C. About 40% of elderly people, low-income elderly people, don't have a single tooth in their head. But that is not a public health problem, or at least not yet a public health problem, or not yet recognized as a public health problem. So it varies from condition to condition how it is defined. So we have to have a lot of data to support to define what is a public health problem. So the next thing is the cost. We have social costs, how much, and what kind of impact these conditions have. So all those things we take into consideration in defining what's a public health problem. In dentistry, for example, dental caries is considered a public health problem because it's widespread. It has got a lot of costs associated with the treatment of the disease. And periodontal disease is likewise afflicts a large number of people. Oral cancer, although it is small, in terms of incidence and prevalence, but it has huge social costs because generally 50% of them die within the first 5 years of diagnosis. So, and cleft lip and cleft palate is another public health problem. So there are programs that we have at the state level to address cleft lip and cleft palate issues. And it's not only that it is how widespread, how much it costs, or what kind of impact that it has, but there are other considerations also. So the first question generally it is asked, is this preventable? And if it is preventable, that problem gets a very high priority. And the next thing is, if it is preventable, whether this is being practiced or whether people are getting these preventive interventions in the community. So if it is not available and if the intervention is effective, that's when the government tries to take action to make sure that these interventions are available. And finally, we have to find out whether these interventions work or not. So, and generally it is undertaken through what we call surveillance activities. And that is, we start with surveillance activities to define the problem and the magnitude of the problem, and to monitor whether the disease is increasing, decreasing, or not changing. So we have to have a good surveillance system in order to monitor the problem. So then we undertake studies, usually some kind of observational studies, to identify what are the causes for these problems. So you identify risk factors that increase the probability of occurrence of some of these diseases and conditions. So once we identify the risk factors, then we try to modify those risk factors to reduce the problem. And that is through interventions, and we have to find out whether these interventions work or not. Generally, we undertake longitudinal studies or clinical trials. Especially clinical trials at the community level, they are very difficult to undertake. So sometimes we have to depend on longitudinal studies or other means to assess the intervention. It's not only how well all these interventions work, but we have to look at the costs associated with that also. So we have very expensive interventions for some of these illnesses, but we cannot support those because the return on those investment may not be all that great. So finally, it's all about implementation, how well we can implement some of these programs. So, smallpox vaccination, when I was studying at Hopkins, there was this big movement to eradicate smallpox. And the vaccination worked great. But Joe Hendrickson, who was the dean at that time, he told us a story about Saudi Arabia. In Saudi Arabia, that smallpox vaccination never worked, because I believe they forgot to refrigerate the vaccines. So when they administered it, it was ineffective. So they found out in Saudi Arabia it was not working. So although the intervention may be very effective, it may not work at the community level. So it may be because how well we implement some of these interventions. So we have to find out not only from clinical trial whether it works, but in practice whether these interventions work or not. So these are some of the activities in public health that are routinely undertaken. So before we look at intervention, we have to know where we can intervene. And the best way I can illustrate is through this diagram here. And these are called the levels of influences. So we can intervene with some of these biological factors that is at the individual level. And there are some factors that can be modified at the individual or family level. And at the community and environment, we can change, and also at the health system level. So I'm going to use an example to illustrate that one. And in public health, we generally like to focus on community and environmental level and health system level changes. I'll give you an example here. I have a picture of gloves here. So when I came to New York, the epidemic of HIV infection had started. And dentists were reluctant to treat these patients. Actually, one dentist from Jamaica Hospital came to our office. He said, "You've got to do you have to do something about this, because we are getting all these strange cases, and we don't know what it is, and we don't know whether we are, by treating these patients, whether we are going to contract the disease or not." So then we started looking at it. It looked very similar to hepatitis B based on the epidemiology, and we decided to make a recommendation that all dentists must wear gloves while treating patients. So that was a dramatic change in the at the system level. And ever since this went into effect, we haven't had an outbreak of hepatitis B from a dental office. So it's a dramatic shift in how the dental care was delivered at in dental offices. And when in the first meeting, we had every district dental societies involved there, and we came up with this recommendation: every dental office should provide gloves, and every dentist should wear gloves while providing dental care. And somebody asked me, "Do you have a glove manufacturing factory by any chance?" Because at that time, there were 100 and odd reasons why dentists didn't want to wear gloves. They said, "I won't be able to perform root canal. I won't be able to trim dentures." And there were many reasons why dentists said we shouldn't be using gloves. But we made that one, and we made that change, and it's we implemented regulations, and OSHA has some mandate, and now I don't think any dentist will treat a patient without gloves. So this is a dramatic shift brought about by change at the system level. And that is something what we are trying to do with oral health care during pregnancy and early childhood. And Dr. Kerpin and Dr. Ron Billings and Sangeeta, they are going to talk more about it. So here's an example. My dream is to free all children of dental caries by age 3. And dental caries has been around for a long time. And you look at HIV infection. HIV infection started in 1983, 84, around that time when it became an epidemic. It started, I think, in 79 or so, some of the early cases. And we didn't know what was causing HIV infection. They didn't know that retroviruses could even cause illnesses in humans. And then there were no tests. They had no idea how to grow the virus. And within 25 years, the whole field has emerged. And now, if you look at transmission of HIV from mothers to children in New York State, it's almost zero. So dramatic change. Sometimes I wonder, with early childhood caries, where the infection bacteria, the caries causing bacteria is transmitted from mother to children, how come we cannot control dental caries in young children? So maybe it's something that we are not doing right in dentistry. For example, if you want to free all children of dental caries by 3. So in public health, when we say free, we are talking about actually prevention and control, because some of these chronic diseases we'll never be able to eliminate, like smallpox. So what we want to do is control. As long as the magnitude of the problem is manageable, then it is okay. So in public, whereas in private practice, we want to make sure that everybody is treated, all the problems are taken care of. In public health, we'll try to reduce the magnitude of the problem. So because if we set up a goal to eliminate dental caries, it will never happen. So we have to be realistic in setting our goals. So when it comes to early childhood caries, at the individual level, we can control the amount and the number, type of bacteria, and we can look at the quantity and quality of saliva. And if there are defects in the tooth, like deep pits and fissures, we may be able to put some sealants, and we can modify the diet. I think one of the speakers is going to talk about xylitol use, and then fluoride exposure. So all these factors we can alter in order to control dental caries at the individual level. And these are children under the age of 3, so it is very difficult to do some of these things. And here, at the family level, if every family supervised brushing with fluoride toothpaste and ensured proper fluoride exposure, and then appropriately feed infants and young children, and stop transmitting bacteria from either through saliva or some of those activities, and take children, start taking children as early as the first tooth erupts, and then get dental insurance because it's one of the important determinants of dental use. So families can engage in all these activities. And then at the community level, we can have fluoridation. If not, we can have an alternative to fluoride program, fluoridation. And then come up with some supportive policies in daycare, WIC, and Head Start, because these are the groups of children who are at high risk for dental diseases. And then we can find and recruit dental professionals to come to rural areas or inner cities, wherever there is shortage of dentists. Communities can create an atmosphere to attract new dentists to come and set up practices. So those are some of the initiatives that a community can undertake, including loan programs and all those things. And then at the healthcare system level, we should have an integrated system where pediatricians can easily do risk assessment, provide guidance, and make referral to dental offices, and link them to a dentist early on, because most young children go to a dentist, go to a physician more often in the first 2 years of life. Come up with a very good insurance product, and then a dental workforce that is willing, ready, and able to treat these young children, and if they cannot find specialists to treat them, and be available in a network, and then come up with standards of care. So if we do all these things, we should be able to eliminate dental caries, or at least reduce it to a manageable level by age 3. So some studies show about 27% of these young children have dental caries by age 3. But if you look at this diagram, these two are very difficult to it is very difficult to intervene in these two levels of influences, because it requires behavioral change. Whereas here it is relatively easy to implement some of these changes. So the early focus in public health is always at the community level and healthcare system level. So later on, I'll use another example with smoking cessation to show how we've been able to bring about changes in behavior. So every president has talked about, every presidential candidate in the last 15 years or so has talked about focus on prevention. And the reason is this one. This is a figure. It shows the discrepancy between health determinants and spending. So health is determined. If you look at the determinants, about 70% of all these illnesses are caused by either health behaviors or some environmental problems. So whereas genetics and access to dental care contributes only about 30%. So it's very difficult to intervene at this level, change genetic patterns and things like that. But if you look at the spending, so we are spending 96% on medical services and only about 4% on prevention. So this is what every presidential candidate during the last debate wanted to change the focus from medical care services to prevention, whether it is obesity. Because of the aging, we are going to be encountering some of these chronic problems in the elderly, like obesity, diabetes, hypertension, cancer, you name it, arthritis. So the focus has to be shifted toward prevention in order to control cost, in order to improve access, and in order to improve quality of care. And roughly now it has reached almost $2 trillion. So that's one of the reasons why in the current healthcare reform there will be so much emphasis on prevention. And when we talk about prevention, it's not only primary prevention. We're also talking about secondary prevention and tertiary level of prevention, that is early diagnosis, early treatment, and palliative care. So this lecture wouldn't be complete if I don't talk about Medicaid, although we don't directly manage the Medicaid program. It is in a different office in New York State Department of Health. And everyone talks about reforming Medicaid, and especially in New York State. As you can see, New York State spends twice the national average under Medicaid. So there are many reasons why we spend more money, and maybe one is more comprehensive care. Other maybe our hospital reimbursement is a little bit higher. More people are eligible, especially elderly under Medicaid. So there are many reasons why our cost is expensive, but you can see our per capita expenditure is twice that of the national average. And it is twice that of California, another big state. And the other trend that is more disturbing is the growth in the Medicaid expenditures. This is overall Medicaid. So New York spends about $45 billion on Medicaid. About 25% comes from the state, 25% from the counties, and the remaining 50% from the federal government. And as you can see, it represents an increase of $15 billion, or 51% in the last 10 years. So the growth in Medicaid expenditures has outpaced the general CPI. So that's one of the reasons why everybody wants to concentrate on controlling costs under the Medicaid program. If we don't do it, then counties won't have money to do anything else. They won't have the money to do roads, bridges, or anything of that kind, because the whole county taxes will be consumed by Medicaid expenditures. So the commissioner in New York State has come up with a prevention agenda to address this one. And there are 10 what they call priority areas. And these are access to quality health care. And I'm not going to talk about the details of these, but I want you to pay close attention because oral health can be part of any of these priority areas. Access to quality health care, chronic disease, both periodontal disease, oral cancer, and caries, they're all chronic diseases. Community preparedness, healthy environment, healthy babies, healthy mothers, infectious diseases, mental health, substance abuse, physical activity and nutrition, tobacco use, unintentional injury. So in every aspect of it, oral health, we want to make oral health an integral part of all these priority areas. So this builds on some of the previous efforts. But this time around, there'll be funding available to undertake some of these prevention activities. So every county and every hospital, they have to collaborate and come up with a plan to address some of these priority areas in their county. This is the first time that hospitals and county health departments will have to collaborate together to come up with these plans. And it's called Municipal Health Services Plan. Every county submits this plan once in 6 years. and they have to do assessment, identify the problems, and then come up with priority areas to address. They may not be able to address all 10. They may be able to address 3 or 4. This is where you can make a big impact. So I want you to participate in these planning processes, talk about some of the oral health problems at the community level, and make recommendations about the activities, what activities you can undertake. So this will be happening in the next 1 to 2 years. So you should get in touch with the public health director in your county and find out when they are going to start all these community meetings and how you can participate and provide input and make oral health a priority. And I'm going to use this one to once again to show where we can make an impact and at what level. And this is a public health paradigm, and this is about smoking cessation. And the example here is tobacco control program. So we want to reduce smoking. I mean, we have seen dramatic changes over the last 20 years. And when I came to the health department, we used to have ashtrays in conference rooms, and there were deputy commissioners who were health conscious smoking in conference rooms. So that doesn't happen anymore. So dramatic shift in the last 20 years. And so this is where the influence at the society and the community level is much broader compared to at the individual level, which is very small. So for example, here are some of the interventions. At the individual level, we can undertake counseling. So every patient who comes in, at any contact, you can talk about smoking cessation. And so on the other end, we can pass a law, and the law was passed. This is about the Clean Indoor Air Act, where people cannot smoke in public places. We can increase taxes, that is excise tax, and youth enforcement, that is where children cannot buy cigarettes, and vendors cannot sell cigarettes to youths. So in between, there are public health, advocacy, health promotion, prevention, and all these different levels of interventions. So studies show that you can talk. Everybody knows about the smoking effect. You can ask about a 6th grader, he will tell you about the effects of smoking, but yet when they go to high school, they start smoking. Because there are, at the individual level, it's very difficult to change behaviors. Because although they all know, some of them don't know, but most people know about the ill effects of smoking. But they don't think they're going to develop cancer. And they use examples of Churchill or George Burns. They smoked all their life and still didn't get. So they'll say, although it is associated, I may not be affected by lung cancer. And then they may say, well, I know I'm going to go, as soon as I develop some signs and symptoms, I'm going to go and see a doctor, I'm going to get treated and cured. So some of those health beliefs will make them less susceptible to change their behavior at the individual level. Whereas if you implement some of these societal changes, like ban smoking in public places, increase taxes, and then stop selling it, and then counter advertising. Cigarette industries have a lot of advertisements on the public health side. There's very little money for advertising to counter cigarette smoking. So press releases with smoking data. So all these things have greater influence on behavioral changes compared to changes at the individual level. So the first focus we like to emphasize at the state and the national level is here at some of these interventions at the societal level. So talking about the prevention agenda, we were able to get 2 indicators in the prevention agenda. So this is a remarkable achievement. So one difference between private practice and public health that I see is, in private practice, a patient comes with severe toothache, calls on Christmas Day, and I've gone to dental offices, I have drained abscesses, and they get relieved, and they call back next day to thank immensely. But that doesn't happen in public health. It takes years and years to make a change. As you saw with fluoridation, it took about 2 years of planning and promoting, and still it didn't happen in Corning. So that's one frustrating part in public health, because you don't see the results immediately. So there are two indicators. One is prevalence of tooth decay in third grade children, and the other one is percent of adults who have seen a dentist in the past year. So we want to increase the percent of adults in every county visiting a dentist. And also we want to reduce the prevalence of tooth decay. It's about 51, 52%. I'll show you some figures later on. And we want to reduce it over the next 10 years. So these two priority areas we want you to communicate to your county health department and also your community members so that we can intervene at the community level. So in order to do this, in order to reduce dental caries and increase dental visits, we have to have a good program at the state level. And the Centers for Disease Control has identified what we call 10 essential elements in a good chronic disease program. And these are, we have to have a board certified or qualified or trained dental public health personnel at the state level, a good surveillance system, and an oral disease burden document, state oral health plan, statewide oral health coalition interventions, and partnerships and evaluation capacity. So I'm going to show you a busy slide where this is called a logic model. This is how we plan our programs. So we take these resources, we engage in these lists of activities like assessment, policy development, and assurance functions, and hope to produce some of these outcomes. And then if these outcomes result, then it will yield some of these benefits. And these are reduction in caries, reduction in oral cancer incidence, reduction in periodontal diseases, reduced transmission of infection, and increased quality of life, and reduced disparities in oral health outcomes. So this is and some of these activities that we undertake that can occur in different levels, and also it can, and we try to integrate some of these activities into existing programs and policies like rural health programs, perinatal health programs, Indian health programs. So there are many programs that we try to integrate oral health into. A couple of things, some of these activities don't take place in our office. For example, financing. We are not engaged in financing of dental care. There's a different office, but we provide a lot of input. And another thing is regulations. Most of the private practice in New York State, they're actually regulated by the state education department, not by the state health department. That's one difference between physicians and dentists. So we don't get into regulating private practices in New York State as a Bureau of Dental Health. How are we doing with time, Tom?
Just fine. 5 minutes to 10. You got more than 35, 40 minutes.
Okay. So maybe I should stop here and ask if there are any questions. If not, I'll go move ahead with my next slide. And this is about the state oral health plan development. We brought in about 100 people. This is one of the essential elements in a good chronic disease program. And this is the state oral health plan document. It's available on the website. And we brought in about 100 people, dentists, dental hygienists, assistants, physicians, social workers, nutritionists, from all walks of life, health directors, and then we started developing the state plan. We asked the question, what should be done in New York State? That's driven by some specific objectives. What should be our objectives? And then that is actually based on some data and surveillance activities that we have undertaken in New York State. And then what could be done to address some of these problems? So there are a lot of things we can do, but we will never have enough resources. But it should be, what could be done should be based on evidence. So not all interventions work, not all interventions have good evidence. So it should be based on evidence. And then what can be done, this is resource driven and the capacity driven. In other words, unless we have the money and the resources, we won't be able to implement all these interventions. So that's the next question. And so based on this framework, we came up with 10 goals and several objectives and strategies, and then we prioritized some of the recommendations, and we are trying to implement. And one of the recommendations was to develop practice guidelines about pregnant women and young children. So because we wanted to control dental diseases in these two particular populations. So you will hear more about it from other speakers. So I'm going to take you through some of the challenges that are identified in the state oral health plan. And the first one is dental caries in children. So it's one of the, it remains the most prevalent chronic disease in children, although highly effective preventive interventions are available. And it's 5 times more common than asthma, the next most common chronic condition in children. And we know, what causes it. We know how to control it. So we just have to implement interventions to reduce the magnitude of dental caries problem in New York State. And we did a survey. We went to every county in New York State. We screened children. We collected data. And it's a very simple technique. Just go look in the mouth and you can tell whether the child has ever had caries or fillings, open cavities, fillings. All those things are counted, and we calculate caries prevalence in third-grade children. We focus on only third-grade. So we screened about, I think, 10,000 children, and we estimated the prevalence of caries. And then these are open cavities, untreated caries in third-grade children. So most of the cavities are in primary teeth. Okay, so not everyone needs treatment at that particular point in time, but it shows missed opportunities to prevent or treat caries early on. So what it shows is all children. So the estimate is about 54% of all third-grade children have dental caries experience in New York State. And our target, this is the Healthy People 2010 target. National target is 42%. No more than 42% of children should have dental caries experience. And in New York State, it is 54%, a long way to go. And what is disturbing is the disparities, because one of the goals of Healthy People 2010 is to eliminate health disparities. And you can see that, low-income children, it is about 60%, whereas in high-income children, it's about 48%. So that disparity is seen in untreated caries as well. You can see here among high-income children, about 23% of them have untreated caries, close to the Healthy People 2010 objective, whereas in low income it's about 41%, way off from the target. So this is, there are great opportunities to accomplish this target. We may not be able to accomplish by 2010, but at least in the next 5-6 years, we should be able to move toward the target of 2010. And this is the national data. And this is looking at data a little bit differently. And that is, instead of prevalence, we are looking at DMFS, decayed missing filled surfaces in permanent teeth, and in all age groups, 6 to 19. So we cannot do something like this in New York State because it costs enormous amount of money to look at every age, so we have picked third grade. Every state has picked third grade as the target at the national level. So here we are looking at decayed, missing, and filled. As you can see, again, you see the disparities. Those who are poor, they have more problems compared to those rich. When it comes to DMFS, you won't see a whole lot of difference between races, especially between African Americans and whites. But you see difference between Mexican Americans and whites and blacks. So this is an interesting, actually, if you go back and look at 1940s, 50s, African American children in general had lower caries compared to white Americans. And that has shifted in recent days. And that disparity is seen in primary teeth at the national level also. This is about mean number of decayed missing filled tooth surfaces among children 6 to 19 years old, and this is again from the national survey. And the point here is that caries is cumulative. As they get older, they tend to accumulate more caries. So traditionally, we have focused on older children because we wanted to control dental caries in permanent dentition. And that most state programs started with older children. Then it shifted to elementary grade children because participation is very difficult in older grades. So now the focus is more on elementary school children. But we have seen a dramatic change over the years. If you look at 16 to 19 years old, as you can see, only a small proportion of caries is actually untreated. Okay? Most of it is treated. But if you multiply this by number of children, you're talking about millions and millions of cavities. So in sheer numbers, you have a lot of cavities to take care of. So that's one reason why we want to start focusing on younger and younger children these days compared to about 40, 50 years ago. And that leads to my, the next slide, where a Kaiser Commission did a report on Medicaid and looked at access to care. So what they reported is, in 39 out of 51 states and territories, and access to dental care under the Medicaid program was a significant or some problems in 39 states, whereas when you look at primary care, only 17 states reported some or significant problems. So only a small proportion of them said good to excellent access to dental care in their state. So this is one of the reasons why there is so much emphasis on Medicaid, improving access to Medicaid children in almost every state, and there are a lot of strategies recommended. This slide is about the money that we are spending on dental care. So policymakers try to look at, they look at the access to dental care problem in states and then look at how much money are we spending. And this is the percentage distribution of healthcare spending among children. So all healthcare expenditure. So the first one is office-based outpatient visit. That consumes about 35%. And the next one is dental care, 23%. So, and the interesting thing is only 50% of all children go and visit a dentist. So if all 100% went, this will easily double. So it will be the major contributing factor to the healthcare expenditure. And here you're talking about healthcare and hospitals. And I'm talking about primary care and hospital. And almost 90% of children go and visit a physician at least once during a year. So when you compare medical and dental expenditure, most policymakers will think, what is happening here? Why are these states complaining about access to dental care when we are spending a lot of money on dental care? So that's why the General Accounting Office recently undertook a report, and this is what they said. Children in Medicaid also fared poorly when compared to national benchmarks, as the percentage of children in Medicaid who received any dental care, as 37%, was far below the Healthy People 2010 target of having 66% of low-income children under age 19 receive a preventive dental service. So you can see why the senators have held hearings in state and also at the federal level on this particular particular issue, especially when a child died in Maryland because of tooth abscess. So this is about coverage and expenditures for dental services. We spend currently about $90 billion, and with a quarter of this spent on children. And about 50% of dental expenses is out of pocket. So that's why people feel these expenses when compared to medical expenditures, because most of the medical expenditures are paid by insurance or some kind of public financing program, whereas dental care comes out of pocket in at least 50% of the cases. So the average annual expenses for children was about $635 under private dental coverage, a third in public dental coverage. So this may be one of the reasons why children on Medicaid have problems accessing care. So part of this expenditure is for, I think, orthodontic care. So if you exclude, I don't know how it will look if you exclude orthodontic care here, but there is a big discrepancy between how much money is spent between, in the private dental coverage programs versus public dental coverage programs. And some more figures and facts here. It's only about 54% have dental insurance coverage, and dental insurance coverage is a major determinant of dental use. And that's why all these policymakers like to recommend increase in insurance coverage. And only about 12% of the U.S. population has public dental coverage, and about 35% of them have no coverage at all. So the percentage of children without dental coverage has decreased. However, there is a lot of unmet need for dental services. So I talked to you about some of these facts and figures, not particularly encouraging, but this part is about all good news. And as you can see here, these are the results of national surveys showing trends in the prevalence of dental disease, that is percent of young children, 15-year-old, who have dental caries from 1979 to 1999-04. It has dramatically declined. So the prevalence of dental caries has declined, and oral health has improved dramatically among children in the United States. And actually prevalence of tooth loss, perio problems, all have declined even in the adults. So with this decline, many changes have occurred in the disease pattern. So I'm going to briefly talk about some of those changes and how it will impact the practice in the future. So in the 60s and 70s, almost every child, especially a little bit older, 13, 14-year-olds, every child used to have cavities. That's not necessarily the case now. So this is about a major shift, and we like to call it polarization of disease. So what has happened is a lot of diseases occur in a small proportion of children. And majority of the children have either no disease or one or two small cavities, pit and fissure cavities. So this one showing that about 25% of the children account for 75% of all DMFS at age 2. So it's at age 17, 25 of the children accounted for 3/5 of the disease in older age group. So this presents a lot of opportunities. In the 60s, we were always talking about standard care. Everybody should get twice a year dental visit. They should have X-rays, fluoride application, prophy, and all those things. But now it is shifting toward more individualized care based on the risk. And that's one important change that the American Academy of Pediatrics and most of the dental schools are trying to advocate, using some risk assessment methods. But one problem is we don't have good risk assessment, objective risk assessment system to identify those children who are likely to develop caries. So because of this, we are now talking about targeted approach, especially in public health programs. So we want to target certain schools. We want to target certain individuals for preventive programs. So, this is one big change in shift. So in other words, if I go to a school and try to provide biennial prophylaxis, and if I do the same thing even in my private office, it may not work. There may be unnecessary or over-treatment for a lot of children. And some children may require more than 2 visits a year, especially adults, especially with perio and diabetes and some of these problems. they may require more than twice a year. They may have 4 or 5 visits. So, we have to change the system to accommodate some of those changes. So the other issue is the distribution of disease within the mouth. So in the past, we used to have a lot of proximal caries lesions. And now it is mostly a disease of pit and fissure in young children. So most of the diseases occur here on first molars in the pits and fissures on the occlusal surface and all the buccal. So for example, caries by surface type in 12 to 17-year-old children. As you can see, occlusal and buccal and lingual surfaces account for most of the problems in young children, that is in 12-year-olds. So that's one of the reasons why we want to focus on pit and fissure caries in young children. And we have a very good intervention available. It's very effective. It prevents 100% of the lesions if it is applied properly and if it holds or retained. And as you see, in this particular picture I selected, because most dentists like to treat this lesion because we think it is already caries. It is easier to treat this one rather than put sealants. So the American Dental Association came out with recommendations actually basically saying that it is okay to place sealants on incipient caries lesions to prevent further progression of lesions. So, but the problem is, about the retention. In the sealant retention, it has to be properly applied and properly sealed, and it's a very technique-sensitive application. So you never know the sealant is going to stay on or not. And we are trying to figure out, the reasons why sealants are not that popular. So I'll show you some figures. And for example, in the Medicaid, the fee schedule is, we increased the fee schedule. It's about $43 per sealant. Only about 8% of all children enrolled in Medicaid received dental sealants in year 2005, 2006. And the utilization is relatively low. This has been around for 25 years. There are a lot of studies showing its effectiveness. But I don't have this picture in my office. What I have is a nice picture of bleaching. So somehow, these companies have promoted bleaching in dental offices, but they have not promoted sealant in dental offices, although it has been shown to be very effective. And there are many reasons, and we are trying to figure out. We did a survey, and this is about the prevalence of dental sealants. If you recall, early on I said, a disease should be preventable, and that prevention should be available to the public. And if you can see the prevalence from our previous study that we did in New York State, this is 2002-2004 data. We went to every county. In New York City, only 12% of them had dental sealants. In the rest of New York, about 40% of them had dental sealants. And again, there is disparity between high and low income. So low income children are the ones who are more likely to get caries, but they are least likely to get this very effective preventive interventions. And why there is so much geographic variation? One reason is in upstate New York, we have a lot of school-based programs. So wherever we have school-based programs, we have been able to accomplish the Healthy People 2010. And our target is 50% of children should, by third grade, should have dental sealants. The reason being, other 50% will not need dental sealants as much. So they'll be mostly caries-free. But we have to apply dental sealants appropriately, those who are likely to get caries. But it looks like what is happening is those who are at low risk are the ones getting sealants, those who are at high risk are the ones not getting sealants. And the reasons for this geography, one is school-based, there may be so many other factors. And it is, we did a survey, and according to the survey, one is it's difficult to convince patients, especially when they have to pay money out of pocket for an intervention that is very difficult to guarantee. And it's easier to do fillings, especially when the insurance coverage is already present for fillings but not for sealants. It's very easy to do preventive resin restoration, and it is likely to last forever, whereas dental sealants are temporary. And finally, about fear of sealing caries lesions. So we are trying to address this caries problem and also to increase the prevalence of sealants. There is very solid evidence for these two. This is a publication by the by the Centers for Disease Control. It's called the Community Guide, which is a part of a family of initiatives. CDC publishes two types of guides, one for individuals and one for communities. So vaccination is a good example, which is covered in both the guidelines. And this is about what community level intervention should be undertaken. It's called Guide to Clinic. One is called Guide to Clinical Preventive Service. The other one is called Guide to Community Preventive Services. And there are two interventions, only two. They looked at everything from mouth guards to oral cancer screening to health promotion, education in classrooms. But they've recommended only two with strong evidence for community level action. One is fluoridation, the other one is school-based sealant program. It is not that CDC doesn't want to promote some of the other things, but what they say is there is insufficient evidence. So that means we have to go out and gather data and see what works and what doesn't work. And so the evidence for this comes from a large-scale study. This is one of many studies. There are systematic reviews. This is called the National Preventive Dentistry Demonstration Program. And it is where they compare different interventions, rinses, lessons, brushing, sealants, prophy gel, and a control group without any intervention. So what they found was, whether they gave, this is comparing fluoridated versus non-fluoridated, whether they gave clinical interventions like all these things or whether they didn't provide, fluoridation made a big difference. And sealants also made a big difference. So these were the only two interventions found to have big impact on dental caries. That's one of the reasons why we try to recommend the use of sealants, school-based sealant program, and fluoridation. So the reason why we are promoting school-based programs is it goes back to topical fluoride applications. Actually, topical fluoride applications started as a school-based program. Every insurance company has picked it up. Dentists started providing in their offices, and all the school-based topical application programs were dropped. So if the sealant rates go up in private offices, there is no need for these school-based programs. So that's I'll answer your question. I'll quickly go through. I think my time is running out. Okay. So, and here is the data that we used in Schenectady to support fluoridation, because what is happening in New York State is many communities that are currently fluoridated, they are debating about the fluoridation program and its effectiveness. I have a paper that I'm working on right now, and it's about Medicaid claims. If you look at Medicaid claims in counties and fluoridation status, there's a very good correlation. So in Schenectady, which is about 70% fluoridated, the claims were like under Medicaid were 1.3. In Albany, which is predominantly not fluoridated, it was about 1.9. So we had a nice editorial in Schenectady Gazette about cost-benefit analysis that made a strong case for fluoridating water in Schenectady, and they kept fluoridation. So this is a battle that we'll have to confront in every fluoridated community in the next. This is about sealants in the Medicaid program. So I'm going to rush through because I think I'm running out of time. And this is about sealants in the Medicaid program, only about 8% of them. And I don't know whether you've seen recently, the controller's office has to put in some controls because of what they call abuse of sealants. And because it was not, some dentists started billing for sealants even in lower anterior teeth. So they had to put in some controls. And here are the policy recommendations. That is, expand insurance coverage, fix Medicaid and Child Health Plus program, use market-based rates, enroll more providers, provide oversight, increase community health centers, test new models, case management, and mobile vans. So in Tompkins County, we studied the effectiveness of case management. I think it increased the participation of dentists in the Medicaid program, and also it improved utilization dramatically, and then promote fluoridation and school-based sealant program. And so when we structure school-based or school-linked programs, the evidence actually is for both school-based and school-linked. So the difference is in a school-based program, we go in and provide sealants on-site. In a school-linked program, actually it is linking the child or the family to a dental office. So both of them will work very effectively. So this is how we like to structure school-based or school-linked programs. So in many schools, there is no need for an intervention other than some policies, whether it is canteens or required dental screening. Those kinds of policy interventions are required in most of the schools, and every school should have that one, whether it is the use of mouth guards, dental screening, or healthy environment like candy machines, good school lunch, and all those things. The next level is non-fluoridated areas. We want to promote fluoride rinse, or if it is possible, we want to implement fluoridation in the community, so there is no need to promote it in the schools. The next level is screening. So very few schools require some kind of on-site screening. Now, with the introduction of the dental health certificate program, there is a great opportunity to promote especially targeted programs in low-income areas. And then either school-linked or school-based sealant programs in even smaller number of schools. And then very few programs using mobile vans or fixed sites in some selected schools where access to dental care is a big problem. So we have different models that we can use to provide dental, either preventive program or dental treatment. So there is strong evidence for fluoridation and school-based program. I think we have shown in Tompkins County how case management can work, but it's very difficult to implement in big counties. In small rural counties, I think it will work very well. And we have the school dental health certificate requirement now that requests dental health certificate. It's not a mandate. And then we are trying to promote dental visit by age 1. So that's all about challenge 1. The other challenges I'm not going to spend a whole lot of time because the other speakers will be addressing. And the second challenge is early childhood caries. As you see, the prevalence is about 28%, and only about 16% of them use the preventive services, those who are enrolled in the EPSDD program. And in New York State, about 4,000 hospitalizations occur in children. Actually, this is 3 to 5-year-olds. The most recent data that I have shows about 4,000 children are treated in a hospital setting. And so this is something that we know. There are 2 risk factors. One is habit, the saliva as an agent for transmission of caries-causing bacteria from mothers to infants, and also inappropriate feeding. So this is one challenge that we are trying to address. And especially, this has attracted a lot of attention now, mainly because in younger children, nationally, dental caries has increased. Whether it is a true increase or not, we don't know yet. Whether it is something to do with the treatment effect, we don't know, or because of the population, underlying population and the sampling that they used. But about 28% of 2 to 5-year-old children have dental caries in primary teeth. And in 6 to 11, about 50% of them have dental caries. And so the reason why we want to focus on primary dentition is not only because it is, it is difficult to treat in very young children, but it's a very good predictor of caries in permanent teeth. So if we control caries in primary teeth, there's a good likelihood that we will be able to accomplish our targets in older children. So there are interventions available for controlling early childhood caries. I talked briefly about it. Another population group that we want to target is improving access to dental care for pregnant women. And I got interested in this topic because of a letter that I got from a physician in Guthrie Clinic, not too far from here. And the letter said because pain was so great, she took excessive doses of Tylenol. And that resulted in toxicity to her and her baby. At the time, she was approximately 29 weeks pregnant. The baby died from liver toxicity. My patient suffered acute liver failure and was flown to Pittsburgh expecting a liver transplant. So this is a dramatic case. We've had several cases like this. There was a patient at Albany Med who was admitted and had to be delivered prematurely. She was kept on anesthetic patch and then had to be delivered early because she had several teeth that required extraction. So we got interested. One of my residents, Dr. Sangeeta Gajendra at that time, we started looking at what are the guidelines. And actually we didn't find good guidelines for management of oral health problems in pregnant women. So we gave money to NYU to do a study, assessment. And what they found out was there was wide variation in the way dentists treated pregnant patients. Wide variation among obstetricians about what they recommended to pregnant patients. So we decided to put together a panel to come up with recommendations. And there was, at the same time, there was a lot of interest. I'm sure you will hear more from Dr. Kerpin later on. And the primary interest is because the infected area in the mouth is quite large. So when there is an infection in the foot, people, as ulcer like this, they run to a physician for immediate treatment. But the same thing which occurs in the mouth, which is about 10 times larger than the surface area, they ignore it. So that's one of the reasons why there is so much interest among physicians in this particular topic. And actually, periodontal disease is a problem, particularly a problem in pregnant women. But actually, 50% of the pregnancies are unplanned in New York State. And there are a lot of pregnant women who will not have seen a dentist or will not have a dental insurance coverage. So they will have a lot of untreated disease when they become pregnant. So when it is difficult to treat them during pregnancy because some of them will have deep lesions, impacted teeth. So you need multiple x-rays. So the question is whether we can take all these x-rays and provide treatment during pregnancy. So there were a lot of unanswered questions like that. And that's why we undertook we put together a panel. And that's one of the reasons why dental care utilization during pregnancy is low. And only about 50% of them visit. And the disparity is large, especially among Medicaid patients. And in New York, about 50% of all, 40 to 50% of all pregnancies are paid for by Medicaid. So it's a large population. But if you look at the total number, it's about 250, 275 pregnancies. Half of them already utilize dental services. And the remaining half, out of that, about a small proportion of them need dental care. So this is a manageable problem. So if dentists, obstetricians, hygienists, and nurse practitioners, everybody got together, we think we will be able to solve the problem, unlike the Medicaid problem in general. And because most of them will have dental insurance probably only during this time of their life, it is better to complete the treatment during pregnancy itself. And that was the reason why we issued the guidelines. And this is a summary that is being promoted by HRSA at the national level. And several states have already adopted these guidelines to improve oral health care during pregnancy. Challenge number 4 is oral and pharyngeal cancers. And this graph is about percent of cases diagnosed at an early stage by gender, race, and year. And that hasn't changed at all. Only about 50% of all cases are diagnosed in early stage. And among male blacks, you can see only about 25% of all cases are diagnosed in early stage. This is for a disease. We know the risk factors: alcohol, smoking, and HPV virus, maybe sun, exposure to sun. So in New York State, about 5 people get oral cancer every day. About 2 people die from it. We know the risk factors. It's easy to detect, yet a large proportion of them are not being diagnosed in early stage. And challenge number 5 is complete tooth loss among the elderly. This is going to be a huge problem in the next 10 years or so, because tooth loss, there are a lot of articles coming out now linking tooth loss. It may be a very good marker for some of the other chronic diseases like cardiovascular, diabetes. In our actually behavioral risk factor surveillance system, we say strong association between tooth loss and diabetes. And there are huge implications. You can see here about 36% of the elderly, low-income elderly, don't have teeth at all. So what should be the standard of care when the next generation of elderly people are not going to tolerate our old type of dentures? They will demand implants. So who should be paying for implants? What should be the standard of care, especially when we are going to be recommending more fruits, more vegetables, less mashed potatoes, but they won't have teeth to eat. So, so how do we address this public health issue? So that's going to be a major challenge in the next 10 years. And then, of course, workforce. Number, diversity, aging of the dental workforce, debt burden, productivity, cost of setting up a practice. All these factors will become a huge challenge for in the next 10 years. If not, it's already a challenge now. And we look at all these issues in our state oral health plan. We have several recommendations to address. And this problem is more severe in rural areas. So dentists tend to concentrate in urban areas, understandably so, especially in New York City. They don't like to move to upstate New York. And as you can see, some of these rural counties, the population to dentist ratio is high. And especially when you look at population to Medicaid population to dentist ratio, it becomes quite evident that we'll have access to dental care problems in several counties in New York State. And interestingly, when you look at the distribution of dental hygienists, it's quite the opposite. So there are more hygienists in upstate New York relatively when compared to New York City. So for example here, so for every 4 dentists, there is 1 hygienist in New York City. Whereas in rural areas, for every dentist, there are 2 hygienists. So it's an interesting distribution problem that we have in New York State. So there are a lot of resources available. There are some websites. You can go and look at all these policy briefs, extensive reports. And one is called the National Maternal and Child Oral Health Resource Center. And on our website, we provide a lot of information about these reports. Children's Dental Health Project, which is dedicated to improving oral health of children, that championed the recent S-chip legislation. You can see the details here. And lastly, media, they are covering these access to dental care problems. This is an old New York Times article that appeared. Boom times for dentists, but bad time for teeth. I don't know why I didn't say bad. It said not for teeth. And and this is one of the reasons why you can see why there is movement in other states to improve access to dental care using dental therapists or other ways to address access to dental care issues in Alaska, where dental therapists are already practicing. North Carolina, where pediatricians are providing preventive services in young children. In Maine, where physicians are extracting teeth. And you've probably seen the legislation in Minnesota, which is going through the committees right now about dental therapists practice. So the message here is, if we don't take care of the problem, somebody will come up with an alternative solutions. So if we have problems in the communities, we have to identify, assess, we have to come up with programs, whether be it in the form of case management or school-based or community health centers, or because we have enormous capacity right now in the private sector, and we just have to figure out a way to improve, to use that capacity very effectively and very efficiently. So one reason there is so much interest in this particular topic now is because if you study the workforce, in dental workforce, there is no career ladder. There is no to move from assistants to dental hygienists to dentists to specialists or through some therapist program. So that may be the model that people will be looking at in the future. Thank you for your attention. Okay. So if you have any questions, I'll be happy to.
Thank you very much. I'm excited about starting to treat dental hearing on medical model. I think it is the only hope we have. But when you were showing the sealant slide, I believe the children with big reduction, you were looking at children who are 10 years old. Was that correct? I think the slide that showed the dramatic health on sealants. I'm a pediatric dentist.
Uh-huh.
And went back and started work in general dentistry. And one of the things I noticed was that children getting sealants on their first permanent molars, then when the exfoliation of the primary teeth, they would then probably at 14, 15 have their premolars in contact with each other, still had the disease in their mouths, because sealants don't eradicate the bacterial problem. So then they would get interproximal caries in the premolars, and it's sort of depressing after you've saved the molars and have caries in the premolars, and which is of course then probably
I see. So is this, you're talking about individuals. There are always cases where sealants will fail. Either sealants will come off, or there will be pit and fissure caries in the same tooth, or proximal caries. Some proportion will fail. But as I said, in public health, we are trying to control the magnitude of the problem, not to eliminate. So if you look at studies, if you look at even the adult population now, okay, they have fewer proximal lesions compared to what it was 40s and 50s. And then we need a combination of fluoride and pit and fissure sealants. So if I put pit and fissure sealants in a population like in Puerto Rico, it's going to be just waste of money.
I agree. It's got to be a combination of everything.
Right.